afternoon, everyone. So, just so that you all don't sleep immediately after lunch, I'm coming from absolutely the ground reality of where the data gets collected from. And almost every week, I think I get invited to attend at least 3 seminars on AI and healthcare. And I'm really wondering, why are we putting the cart before the horse? And it's something that's been a challenge. Do you have to advance the slide? Yeah, the slide is not complete. So really not wanting to sound very pessimistic, because I'm actually very optimistic that the way to go in healthcare to really optimize the healthcare delivery and to address most of the problems that we have faced, that we've been talking about, at least since the time I've been in medicine and even before, the solution lies in use of digital technology. But the fact is that are we really running a bit too fast, forgetting where the basics are and where we should concentrate our energies on? And this doesn't. So, what is it? Oh, okay. No. It should go like this. What's happening? It's not moving.
Or you just said
okay, all right. No. So, to the crowd sitting in this room, these are the most commonly heard words these days. Precision medicine. I don't think half of us really know what do we mean by precision medicine, but we all want to talk about it because that's the done thing. And we of course think that by using AI, we are on the road to digital transformation and we'll address all the ills that have been affecting the healthcare system, which is mainly access, cost, all of the stuff that regularly talks about. This is.
It just does that.
Okay. No, it's I think it's. So just to let's get back to the actual defragmentation of this healthcare ecosystem that we have. It's easy to see an Apollo or a Fortis or a Max and go to the hospital and think that everything under one roof is fine. But we are talking of healthcare right from cradle to grave. And we are looking at PHCs, we are looking at totally different kind of healthcare delivery systems, whether it's allopathic or totally different alternative systems. And within each system, again, there is no continuity of care. If I go from one hospital to the other, there is no continuity. If I go from one Apollo to the other Apollo hospital, there is no continuity of care. And of course, if I move cities, countries, then completely gone, right? But what do we think that we need to do? Or at least, what is that we imagine sitting in this room? Is that this is the kind of connected care that we want. And this is what we expect that digital technologies or use of technologies will do. And I do believe that it is possible to get this seamless connectivity. Working in the field and knowing what is the potential of correct use of digital technology. It is possible to do this, but it is possible to do if we do it in a very rational manner. And if that was not enough, the government has also realized now that if it wants to fix the healthcare system in the country, then Ayushman Bharat is the scheme and this digital health scheme and using the health data is the way forward. Now getting down to basics. What is health delivery? It is nothing but data management. What do we do conventionally? I as a doctor speak to a patient, gather some data from them in their history, examine them, again collecting data, and I process it in my mind. I process it with the knowledge that I have gained, with the journals that I have read, with the patients I've seen in the past, and with the friends who have seen more cases like that. So that has been happening, and that is healthcare delivery. What has changed now is the processing and collection. So let's say the technology with which we collect the data, we have got better technology. So instead of writing down on a pieces of paper, I actually collect it so that I can compute it in a better processor rather than my individual brain. So that every patient that I see gets the benefit of collective brains of multiple doctors having seen that. And that when you cumulatively go across, number of years, millions of patients similar to that person that I treated, I get the benefit of decision making which has been done by many other doctors. So when I said that we can do a good, seamless, collective data delivery of healthcare, it is possible. That connected care is possible. Now, instead of just a pen and a paper, we have got different sources of data inputs. And this is where our problem lies. Who has to collect the data? Mainly the doctors, nurses, the technicians who work in a healthcare delivery system. And today, with a lot of apps and IoT devices available, the patients who wear all these bands and everything, or the remote data collecting devices that are available. So even the patient and their families and the caregiver are also collecting data and putting data into the system. This complexity of different types of data, some of the devices which have not been validated and therefore causing problems of collecting similar forms of data, is where most problems lies. I'm sure most of you who have been part of digital health seminars, they will say doctors are not helpful, they are resistant to change, they don't input the data and therefore it is not available. Now, why is this? Because the technology providers create some technology solutions and tell the doctor, this is it, now you treat the patient according to this. Do they ask the doctors what is the process that you follow? It is like, I remember when, in 2003 or something like this, one of the patients that I was supposed to operate the next morning, her son comes to my office around 9:30 and gives me printouts from internet saying that, doc, before you operate on my mother, please read this. I told him I spent 13 years becoming a neurosurgeon. Why don't you take this, read this, operate on your mother? This is the problem with the kind of data that we are depending on. Okay. And that is where, so if you have not asked the people who are on the ground who have to deliver the care, does anybody ever ask the nurse, how do you have to measure the blood pressure? I was telling him a while ago that I bought a device which is supposed to immediately, within seconds, you tie the cuff and immediately the BP pops up and it gets transferred to the EMR. Well, gave it to the nurse. Now they had tested this equipment and they're marketing and minting money on it with just one cuff. They don't know there are 3 to 5 different sizes of cuff, and cuff size makes a difference in the blood pressure parameter. Right? Did they take inputs from anybody in healthcare? So this is the problem that I see on ground, and it is not getting less, by the way. Now, what do you expect AI to help us with? That is processing that happens in the brain. So the volume of data that I can process and the speed with which it can be processed can be enhanced. That is what we expect the technology to help us with. So giving you an example. Now, can you imagine, let's say, robotic surgery. Everybody wants to go for a robotic knee surgery or a robotic kidney surgery. Can you imagine if the data input in the primary data that we input for surgery, if even one parameter is wrong, what do we expect as a result? Right? Nobody would want to go near it, right? Similarly, I'm sure you must have heard of, a very big company that had to close its CDSS and AI operations because the benign breast disease in a lady was diagnosed, a malignant breast disease was diagnosed as a benign case, and 6 months later she had florid spreading cancer. Okay, and this is not just once. I think they had it 2 or 3 times in different situations. And why did this happen? Because the algorithms which were written for helping the diagnosis of a breast tumor were based on data which was not right, which was incomplete, which was maybe incorrect, which was, half the time when you write the case sheets, you can't see what the doctor has written. Maybe some of us can't read our own handwriting. But that apart, this is what happened. And a company that had invested billions was sued because this one lady, young lady, 6 months later, succumbed to stage 4 malignancy. So this is the danger that we are putting our patients to. So if somebody says that doctors are not willing to adopt technology, this is the reason. Okay? How would I want supposing I'm a medical oncologist, how would I want the CDSs to help? Now I presume all of us know that in cancer, chemotherapy is usually done over a few cycles, 6 to 7 minimum. And the drugs which are started on day 1 may not be continued because it depends on the way the tumor is responding. So we have multiple parameters to assess. There are also dose variations, even if the drugs are the same, because the patient is losing weight, patient is nauseated, patient has got a lot of other side effects. Now, each visit the patient makes, the medical oncologist really has to do a lot of hard work in figuring out if blood count has, blood count went down, patient got growth factors, patient is losing hair, having metallic taste, has lost so much of weight, all of that, and have to work the dosage of the drugs and whether it is adequate for the tumor, because you're also measuring the tumor size, whether it's decreasing in size, remaining same, necrosis there, not there, all of that stuff. I would love to have a solution which, in a cyclical manner, looking at these parameters which we are giving the inputs in the system, can immediately throw up a solution saying this patient, 3rd cycle, tumor has responded, but patient has had these issues with white blood count, change this drug, reduce this drug, advance it by another week, or so on. If we can get those complications sorted out, believe me, doctors will be the first one to adopt, right? Who doesn't want life to be made easy? Right? So literally, when we talk about digital transformation, it is nothing but using all the available technologies to us and using the data that is available to us to actually automate and create this whole digital transformation journey. But it doesn't take away the fact that to start this journey, you need to have timely collected, accurate data, which is, at the time of the event, which is very reliable, and it is complete in the respects that it is needed to be. I'm not saying that you have to have 5 pages for application, but where it is required to have 10 pages, then 10, but where it is required to have 5 words, then 5 words. But we must know what is relevant, and that input But that input can only happen if the doctors are part of providing this technical solution. And I'm not saying doctors, but doctors like any healthcare providers. So, it's a non-brainer that okay, you have a lot of benefits for use of AI and these highly, developed solutions and algorithms. And we also know that there are ethical solutions and privacy concerns, and Dr. Pal will be talking about the privacy concerns and things like that. But I want to address this black box problem. It is like, you tell me the CDSS, it's the same story, right? I see a lady, she has a breast lump, and says, okay, treat her as well. Who tells me, where is this data coming from? Who has said this? Who's written this algorithm? Was this guy sleeping when he was writing it? I don't know, right? So this is an issue which we need to have more confidence from the technical community that these things have been addressed. Of course, doctors also want that our life should be made easy. we should have less burnout, we should have easier, less things to remember. I remember as an intern going around with this book, because I would not remember the dosage of the drug. Every patient that come after that, after reading, seeing the history, I would have to refer to this tuberculosis ka dose kya hai, that kind of stuff. You go for 2 months, come back, you would have forgotten all the doses. Now with all this, you don't need to remember. So it's a great tool to have, but we have to accept the challenges as well. So while we are actually, this whole landscape of healthcare is evolving from a doctor-centric, individuals, hospital-centric, very secretive, compartmentalized care system to a much more wider sharing space that we have. We need to understand that we need to work together. This is a time when the healthcare data solution provider is not just a vendor for us. It's actually, they may be vendors in transactional sense, because we pay them for the solutions that we buy, but in the reality, in a functional sense, they are also healthcare providers. And they must share the actual liability for healthcare mishaps that today only the healthcare system or the healthcare provider, trained doctors and nurses, and the hospital check. So they are as much a stakeholder in healthcare delivery as we are. And if that is well understood, then it is necessary that the first step that we have to do is have tools which can help us capture mineable data. So when do we say that we have arrived? When we find that we can speak to every data collecting system that is existing, all systems are interoperable. We can speak to all the legacy systems that were set maybe 10, 15 years ago, and today it is very difficult to get data out of those. We need all of that to happen before we are comfortable saying that, okay, we have arrived. So if you don't have correct data, how many of you have traveled to Delhi in fog and hope like hell that the ILS is working? So if the ILS is not working, this is what will happen if you don't have data. Thank you so much. This is my
Thank you, Uma. We have a small memento for you.
Oh, thank you.
This is what
Supposed to put it on the screen? Thank you so much.
Thank you. Yes, ma'am.
Thank you. Can you hear me? Is this working? Hello? Thanks, Uma, for that insightful and very candid talk that you gave. Always a pleasure. And our next speaker is Dr. Devnath Pal. So, Professor Devnath Pal is a professor and convener of the Biomedical Computation Laboratory at the Department of Computational and Data Sciences at ISC. His research is primarily devoted to the area of computational biology and bioinformatics. His group focuses on analysis and development of methods to better understand biological function in multiple spheres. Particular areas of focus are genomes, transcriptomes, proteomes, and metabolomes. His group emphasizes improving accuracy of results and developing generalized and accelerated solutions. But today he's going to talk to us about data privacy.
Thank you. Thank you for the introduction. It's not relevant
Okay.
to the talk that I'm going to present.
So I saw After Dr. Paul finishes, we'll just do the questions for Dr. Paul and Omar together. And then,
Yeah, because I need to, so you finish
No,
your talk.
you can have a question.
Other questions?
Oh, if
Yeah.
you have any questions,
hey, anybody has any questions for
Because
Omar?
I am
I'm sorry.
sorry, sorry about that.
Any questions for Omar?
Just a,
We can hear you.
oh, yeah. Is there any particular, do you find fuzzy expert systems of any relevance looking at the things you were trying to point at in your talk? Like, I think there's a lot of, could see the early slides were mentioning about expert systems kind of thing. So, because most of the present day systems are all based on heavy, energy expensive machine learning. And that may not be, as you rightly point out, it's only as good as the data that went into training it. Whereas fuzzy relies a lot on medical professionals' knowledge, which I think takes one far ahead in the game, and it's also much cheaper also. It's explainable, yeah.
So the thing is that we have the electronic medical record systems and the hospital information systems. There are many of them. Like in India itself, there would be more than 200 odd EMRs and DHIA systems that exist. Now, when we evaluate them to understand who has got the depth of how much clinical data can be recorded, and it is necessary for the place where we actually miss out is that the doctors who are buying, or the hospitals that are buying these systems, they do not know how to communicate with the technology solution provider. So this gap in communication is one of the main things why we end up buying wrong things. And you would have seen during COVID, there is this immediate shutdown happened. Every doctor or hospital within the next 1 week had at least 10 telemedicine solution providers knocking at the door. After 2 days, they would not work. Because they have just tested that, okay, it's like, when we were kids, you put a matchbox and you go to the father's room and say, okay, you can hear what I'm saying. Telemedicine solutions actually came like that. And we have, at that time, I along with 4 or 5 people, evaluated 160 telemedicine solutions that were floated in the market within 3 months of the COVID lockdown. And not more than 20 actually served the purpose of even meeting the telemedicine practice guidelines that were actually released on the day COVID lockdown happened. Many of them did not know what are the basic criteria required to practice telemedicine. So, and the doctors did not know. They would buy and then after 1 month, kaam nahi kar raha hai, shut down. So this happens in all the EMR solutions and all the HIA solutions. This is the problem, but having said that, there is a breed of technologists as well as doctors and nurses who are now working together to develop solutions. So that's the bright side. So the problem is understood by people. We have all faced it. We've all faced these problems of changing from one EMR to the other and migrating data from one to the other, and then figured out that, okay, no, we need to work together. We need to be on the same side of the table.
I have a question regarding that. If you look at the West, right, the doctors are really jaded because they have these legacy EMR systems. I don't know people who quit medicine because of it. But do you think now that we're in the ground floor here, instead of adopting those systems, isn't this an opportunity to build?
So we are building. In fact, most of us, I would not go anywhere near Sadhana Varate because it's sitting on so much of, heavyweight legacy and they're so expensive as it is. What we need to do is, as I said, what is it that, what is tiring those doctors who use Epic and Sana? You have to go home and type what you have seen in the day because you didn't have time to type all the case notes. And why they have to spend that 2 hours after dinner? Because they won't get paid otherwise. What we want, can we do easy intuitive speech to text learning? I think there is a lot of it that's happening today. And we are, in fact, in the hospital that we will have a fully digital hospital. We are going to address these problems where doctors, nurses do not have to waste time on data inputs. They should spend less time. They should actually be able to validate what is being written, not just click some drop downs and then don't see and it just goes into some space and you don't know what you've clicked in the drop down. And I have seen cases where in the drop down wrong medicine has been, instead of a respiratory stimulant, a respiratory depressant was given because it was in the next row. It got ticked. Doctor cannot validate after ticking, and the patient was on ventilator within 5 minutes. So these are mistakes that happen. So we need to understand and we need to see how to correct all this. But there is a lot of development that's happening by people in India that I can see, and also of course a lot of companies outside our country.
So like I have a question, like if we are working on the grassroots level of the Indian villages, like the private healthcare center, we don't have the luxury of having this kind of electronic system there. How do you plan to integrate that data?
You actually have. In fact, the basic in the Ayushman Bharat Digital Health Mission, the basic is capturing some data electronically. Now they have given a minimum data set which should be captured, and there are systems which allow you to capture. They actually test with different EMR solutions, and they are still in the evolution stage where they are testing which one will work best. But they say okay, give diagnosis, your lab orders, your basic stuff, okay, and then we'll go to the next step and the next step. Because if you have to, get so much of data, you need to start somewhere. So government has clearly given you what you need to do. And in fact, in India, you would be surprised. The rural India, if Ayushman Bharat schemes were to be adopted well, and it really goes well the way it is implemented by the government, we will have more electronic data on those populations than in the private hospitals where we work in silos and we don't check it.